All right, good morning. So a lot of the principles you've heard already, I'm going to talk about briefly, but essentially the reduction is what Jeff talked about already. So we've already heard a great talk on pilons and a good talk on plateaus. So I'm Payam Tabrizi. I'm going to share a couple of cases with you guys. So this was a 50-year-old male. He was in a motorcycle crash. He had a small closed head injury, pneumothorax, was seen at an outside hospital. An x-ray showed this bad bicondylar tibial plateau fracture. They didn't have an orthopedic surgeon that was confident in trauma, so they splinted him and took long film x-rays showing there's nothing below. And when he showed up at our hospital, this was his clinical picture. So within a few hours, he'd already developed bad fracture blisters with pretty significant soft tissue injury. So obviously, he's not ready for an early definitive fixation of his injury. So you've heard this principle before by my colleagues, but essentially for these, I tend to take them to the OR pretty much right away if I can get OR time, try and get length of the fracture and let the soft tissues recover. The key is, I think, also to put your pins in a place. They could have been a little bit further down, but so they're not going to get in the place of your definitive fixation. And if you're going to develop an infection, if it's going to be weeks out, it's not going to cause a problem. So here, hopefully, we got a little bit of length out. I usually don't try and get a CT scan before the injury or before the X-fix. I try and get it after, just to see how I've done with my X-fix. There's the lateral view showing that the fracture seems to be out to length in the metadiaphyseal area. And again, I use the fibula as a judge. If the fibula looks like it's length stable, then probably the tibia is as well. So here's our CT scan, shows a very comminuted fracture. Coronal views show that it's bicondylar, there's central comminution. And I specifically look at the lateral. So I'm looking for a coronal shear fragment. I'm seeing if it's out to length. And this helps me with my approach and also where my fixation needs to be. So we waited about 3 weeks for him. His tissues took a long time to recover, and he spent a good portion of that in hospital. He didn't have any resources, so he couldn't really go anywhere. So we had a good observation of his soft tissues. And about the 3-week point, we took him to the operating room. When there's a posterior fragment, I actually flip him prone. I do a Lobenhofer, so I do a straight posterior incision and try and get the posterior fragment out to length. Here you can see some small zone-specific fracture plates for the central comminution. And then if I think the soft tissues are amenable, I actually flip them and do the lateral component at the same time. If they're not, then obviously you'll have to bring them back. The one problem with putting them prone is you sometimes have to take the X-fix off early because you cannot position them prone with the X-fix pins in. So here you can see the plate's way too anterior for the lateral plateau, but that's where most of the fragments were, and so that's where I decided to put the plate. Post-operatively, it looks pretty good. Again, the plate is very anterior, but I thought I achieved a good reduction of the joint and pretty good restoration of the metadiaphysis. He came back about 3 weeks for suture removal. I still had a good reduction, but then this happened. So I'm gonna leave it to the faculty is what you would do now. 3 weeks out, his wound is dehisced a little bit. Would anybody take him back and do anything else? Would anybody sit through this, bring him to the hospital for antibiotics? So I'll leave it open for the panel as to what they would do now.
Pam, I think once you see that, that's go time, unless there's something else about the patient that is precluding you from going back to the OR. That's a sign of either it's a deep infection or it's going to be if you don't do anything. So I tend to try to take those patients back, and I've yet to regret doing that. Occasionally you come out with good news, but most of the time you're find out exactly what you expected.
Yeah, I totally agree. I mean, the literature says a bicondylar plateau with soft tissue injury like that has a 50% infection rate. So we know the complication rate is really high. And when you see that, you know that if you peel off that yellow stuff, the metal's probably sitting right under there. So I'd be pretty aggressive with this. Take it back, wash it out. I would probably take out all the metal. I'd get my reflapologist involved, although that could probably be covered up with a gastroc. And then at the risk of sounding repetitive, I would probably put a ring fixator on that.
So as you can see, the next day, you know, we admitted him to the hospital. The next day, the wound completely dehisced. Now you're looking at metal. So we actually took it out. As you mentioned, I actually put him in an X fix, but I didn't go across with pins. I went right back into his distal femur. And eventually I got him healed. We were able to close the wound directly with the anterior plate out. So we didn't actually have to have a plastic surgeon do any type of flap. But once that plate came out, we were able to debride it and close it over drains. And I've seen him back at about a year, and he's stiff. His knee is stiff, but you know, he has pretty good pain control. He's walking, and fortunately, he didn't develop any deep infection that result in further problems. So I think the key is, for me, what I've learned from this is it's okay to go, you know, if you're going to do it and flip them over and do the lateral part, you got to make sure the soft tissues are amenable. If not, I think in the future, I'll probably stage this, let the tissues recover, or do something else. So this, for me, I think the plate was too anterior, and obviously the soft tissues weren't ready for dual incisions at this point.
Yeah, so the plate ends up becoming like a soft tissue expander, right? If you end up with a little bit of redundant tissue, so that's cool. Just for the folks who are watching, I'm curious, and myself too, on a case like this, do you consult infectious disease? And did this guy get a PICC line and 6 weeks of antibiotics and stuff like that? Or did you take cultures? Did you send a bone biopsy? How did you manage the infection piece of this?
So I'm a little conflicted with consulting ID. A lot of times they say all the metal has to come out. So that's my issue. Consulting them on this case, they're going to say, we're going to have to take the posterior plate out too, even though it's way away from the infection, unlikely to be involved. And then you've got a very unstable fracture. So when I think that they're going to recommend everything come out, I usually don't consult them. And I have the hospitalist manage the antibiotics. This guy got 6 weeks of antibiotics. We did take cultures. I'm a little bit weary of taking cultures when the wound is exposed because it's going to grow everything under the skin. So even though I cultured, I'm a little bit careful about making sure that what I'm treating is right bacteria. But I'm a little bit reluctant to get ID unless I think the guy's at risk for losing his leg, in which case I think what they recommend is appropriate. Take everything out.
That's great. You have
Other
another one?
questions from the
Tom?
audience or panel?
I don't see any other. You have another one for us, Pam?
Yep. So this is a case from a colleague. It's a relatively older patient who had a mechanical fall, sustained this osteoporotic type fracture. It's looks like it's extra-articular, but hard to tell. It looks like it's mostly metatarsal, but a lot of comminution and a lot of instability. So whenever I see any fracture close to joint, I always get a CT because I've been fooled thinking it's all extra-articular. And this fracture does go into the joint. It's not that involved. It's kind of like the pelon I was showed. It's barely intra-articular, but it is. Other images show the same thing. It's in the joint, but not too bad in terms of the articular congruity. So again, I like X fixes, even if the soft tissues aren't a problem, because I think it lets you get the fracture at the length. It allows you to have some time to plan the surgery. So most of these axially unstable fractures get an X fix, even if their soft tissues are appropriate. And then I plan the surgery. So on this, we took him to surgery, left the X fix on, did a lateral plate, bridged the fracture. You can see we used a screw to compress the plate to the bone. And he did have a tibial tubercle piece, so some front to back screws for the tibial tubercle. But it looks like possibly it's a little bit distracted looking at the lateral view. So I put him in a brace. This is early on. So it looks okay early on. And then within a few months, he starts drifting, and then you have failure of fixation. So obviously it wasn't very stable. The plate is intact, but the screws have all fallen apart. So the patient's unhappy. His leg looks crooked. Again, I'm going to poll the audience, see if anyone would do anything different at this point. He's an older guy. Would you leave him, let it heal?
Boy, Pam, you picked a good case here, because these short segment extra-articular fractures, I think we could probably talk for a couple hours about different options. Are we going to do lateral only locked fixation, dual plating, medullary nailing? What's the what's the best way to do this? And I've drifted away from lateral only plating, because of this type of thing. It's just usually a lot to ask of one's plate. So at this point, I think I would revise it and nail it. But the literature says you can do whatever you want. So
I'm gonna just add that our attendees can put a thought into the Q&A. We won't be able to necessarily get to everyone, but we can see what they're thinking as well while the panelists continue to share their thoughts.
So I agree with you. This patient had a revision, added a medial plate. We were able to kind of distract medially and get the fracture at the length, and then did a separate medial plate and was able to get him restored. And he went on to heal uneventfully. But again, I agree with you. Lateral plating, even if you think you have locked fixation in these short segments, it's bound to be unstable. The other thing I've learned over time is some of these fractures are better served with an intramedullary device. You can put lag screws across the joint if need be. You get much more stability. Patients can probably weight bear a little bit earlier, and you don't have as high a fixation failure rate as just trying to do a lateral plate. So with the newer techniques of nailing, I think that's become more vogue to do possibly suprapatellar nailing of these, or conventional nailing with blocking screws and newer techniques. But I think that these fractures can be problematic. People look at these and think, well, it's a simple fracture. It's mostly extra-articular. I can use conventional techniques. But as you mentioned, they're risk for high complication rates.
well, this final looks great here. So you got him where he needs to be. Dr. Rohr looks like he wants to say something.
Oh, I was going to say what he just said, basically. I mean, I love nailing these, and I like doing nail plates, like a little tiny, if I need more than like a 4-hole anterolateral plate, I won't do it. I'll nail it and just put a small plate for the fixing the joint piece or whatever is up there in the metatarsal region. And it's never a problem getting the nail past the plate.
What about a hybrid or a circular fix, Tony? You said you're a fan of circular fix. Would you ever?
A TSF would have been a good solution for this problem, or even an old school Ilizarov. It's patient specific, right? So like if this guy was a chucklehead and, difficult, I might not choose a ring fixator. Like what I would have done in the 2 slides back when he had the failure, I would have just nailed that and let him weight bear on it right away. And I would have put all 4 crosslock screws in proximally and 2 distal. And just the reaming alone, I think, would have stimulated that thing to heal. But if he had, some reason why I didn't want to nail it, like maybe there was a smoldering infection or something like that, that's a spectacular case for a ring fixator. And I would also let him weight bear on that.
All right, excellent discussion. Any other of the panelists or anyone in our audience have any questions about proximal tibia? All right, well, if that's the case, we can move on 5 minutes or 4 minutes early here to
Jeff, let me try So, you guys did a fantastic job in all these cases, kind of highlighting fixation versus, reduction techniques. I mean, there is an example where reduction initially succeeded. Maybe it was a little over distracted, but perhaps not. And the fixation was the problem. Other cases where, it's very much about the reduction. And I don't want to suggest that you can do fracture surgery with one or the other, but maybe take my challenge on both of you panelists, you and Pam. Like, if you had to have only one, if you could only reduce or you could only fix, what are you going to take in a proximal tibia fracture like these?
I mean, one of my fellowship mentors said that it's much easier to hold a reduction than a malreduction. And I think there's something magical about putting things back where they belong. Just it does make it much easier to hold on to things. If you've loaded the bone, whatever fixation you do have is going to be more resilient. And so, I think obtaining an adequate reduction is the cornerstone of fracture surgery. The fixation just has to follow our principles, and you can be as creative as you want there, but the reduction is everything. So
Pam?
So I agree, but for me, it also depends on the patient. So if it's a patient who's older and I want to make sure they don't have a big complication, I'll take a little bit of a malreduction if I can spare them a complication. So we talked earlier about some of the pilon components. If it's an older person, and we heard that from the osteoporotic fracture lecture yesterday, I'll take a little bit of malreduction to try and get them stable and ambulatory right away.
And I think you guys did an excellent job of explaining that both are important, but I thought I'd challenge you on that question. Thanks so much.
And I think timing is equally important. From that first case, maybe 3 weeks is early. So I think the three components are probably reduction, techniques, fixation, but more importantly, timing, whether it's physiologic for the patient or just the soft tissues not being ready.
Just out of curiosity, on the opposite cases, would that each of you presented, would the other panelists have approached that fracture differently, and how might you have done that differently? So Jeff, on this one, what would you have done from the beginning?
I would have nailed this. Reduction with a distractor or some sort of intraoperative traction device to restore alignment, and then a medullary nail with lots of interlocks and blocking screws.
And then Pam, I don't know if you remember, should be able to on Jeff's case, what might you have done differently on his?
To be perfectly blunt, I would have done pretty much the same thing. And I probably would have nailed this case as well. But I think you learn with experience, and this was one of my earlier cases. In hindsight, with the suprapatellar nail, I don't think it's an issue. I think the plates maybe for this are more prone for complications. So I think it's, what you mentioned about it's a fellowship of learning, and I think we learn from our mistakes just as much as our successes.
And it's it does bode to what we do well. I mean, you start getting into a little bit of a pattern of a series of cases that go really well with one technique, and then you see a fracture that's kind of close to it. Maybe it's a little bit more distal and you could nail it, but so it's us trying to always do better, I guess. So I'm a little, I try to be less critical of what I and others do, because a lot of times we're doing it with pretty good intent, and certainly we learn from those things, but it's sometimes realizing that each case is a little bit different, and maybe that one, once that lateral plate's put on, it's, looking in and saying, hey, now that I've done this, I want to go to the medial side and put the plate on right away. Or again, there's a lot of patient factors that you guys have alluded to, but it's, where some people are jumping ahead, they've seen certain complications and they want to go straight to a nail. That posterior tibia case of yours and the posterior tibia case of Jeff's, where, you guys went right to that because you knew that was going to be an issue. I think those are all super, super good points on pretty tough cases.
And, I mean, I think you mentioned it last night, Jeff, talking about, having people you can discuss things with, but it's typically really easy to see the faults in other people's surgeries. We can all do forensic stuff, but it's harder to see your own errors, usually because you wouldn't have left the operating room if you thought you were doing a caca job. So showing them to people that you trust and saying, can I pick your brain? I this is what I think I could have done better, but do you see anything else? What would you do? Have you had this problem? And getting feedback from colleagues is really helpful to try to fix it the next time. So,
and I think you guys also did a really good job of showing gray cases, like where there's a bit of a gray area where what one person does might be a little bit different than another, and these are the tough decisions that we're making. It is often in the gray area.